Urologist now he is working hard. Now all of you know his service is giving so much of giving service all over Assam. So now may I request Dr. Oruf Naf to start your presentation.
Thank you, sir, and good afternoon, respected chairperson, sir, my teachers and friend. Frankly speaking, I was so mesmerized by the lecture Manoj Saha sir delivered. I just forgot that next in the line is me. And I would have liked a few minutes from my slide to give to sir. And I would have even liked if he could cover posterior urethral valve also. And I was thinking that the whole pediatrics you need 2.5 days conference, but Saha sir could finish whole pediatric surgery maybe in 20 minutes time. Wow. So my topic is a nightmare condition for all stakeholders, the parents, the gynecologists, the pediatrician, and the urologist when you refer to me. So as the time has been curtailed by 5 minutes, so I'll not go into much detail in the etiology, clinical features, pathophysiology that you all know much better than me, I'm sure. I'm just a carpenter. If you send the patient to me, I'll correct it with the most advanced tool available. Beautiful saying by Sarak Samhita 40th chapter, 8th shloka, that Soriram Sintoyotu Sarvadeva Manusha Sampada Sarvabhave Yato Tasmat Sorira Sthanam Ushote Iti Otto Janma Maranam Shamyak Udaharanam. How, in spite of all the guidelines, classification, and descriptions, each and every human body is different. So when we treat a patient, it will be different from other, and we need to take that into consideration. So minimal invasiveness of endoscopic approaches combined with refinement in endoscopic instrumentation have led to evolving interest in expanding application for their use, and now include incision of posterior urethral valve. We aimed to report our pediatric experience of posterior urethral valve incision using the most versatile and the most recent thulium fiber laser. Many modalities of endoscopic posterior urethral valve incision has been described, including the electrocoagulation with Bugby electrode, diathermic snare, Whittaker cerulean hook, Hoyak laser, thulium yak laser, and thulium fiber laser. All those marked yellow, I have the experience. I started with Bugby electrode, then holmium yak laser, thulium yak laser, and now I am doing with thulium fiber laser for last 4 years or so. And I have seen how it has improved. When we do with Bugby, then immediately at the time of fire, there is a sudden jerk because of the sphincter contraction. There is always chances of injury. There will be bleeding, chances of injuring to the sphincter leading to incontinence and stricture. Then I started using holmium laser, as it is a splitting laser, so you cannot cut precisely. Thulium egg laser, beautiful laser, but as its penetration depth is 4 times more to thulium fiber laser, there is some, when you do with thulium fiber laser valve ablation, there will be some tension back of the mind that you may injure the external sphincter. But with thulium fiber laser, as it has the least penetration depth of 0.1 mm, so we can do it with much confidence that we are not going to injure the external sphincter. It just extends from the verumontanum and will go towards the external sphincter. Then type 2, it is of academic interest only. The valve goes from the verumontanum towards the bladder neck. And the third one, which is most severe, and it is a membrane-like. It is a membrane just distal to the verumontanum. As I have said, the most common is the type 1 valve, and the type 3 is 5%. This is the endoscopic view. So on retrograde passage of the endoscope, you do not see much of the leaflet, but while coming back just distal to the valve leaflet, by stopping the inflow and opening the outflow of the endoscope, you can see the valve leaflet then gradually projecting in the lumen. So this is the type 1 valve. You can see that valve, it projects like this towards the distal urethra. This is the type 3 valve, so it is more severe. Clinical presentation nowadays, because of the availability of prenatal ultrasound, and the most of the mother, expecting mother or pregnant mother, going to get the ultrasonography and gynecological consultation, more and more patients are now being referred to us by gynecologists. Hydronephrosis, unilateral, bilateral, bladder overdistended, and keyhole sign and all. So after the baby is born, the abdominal mass suprapubically, maybe the kidney also palpable. Sometimes there is ascites also, then other respiratory thing. Presentation also. So it may come earliest just immediately after birth, or before birth also when the gynecologist refer. After that, in the later part, and the later the presentation, less severe is the valve. We have slender ureteroscope also, so 6.5 ureteroscope also we are having. So even for us very small for the baby also we can do. So how we predict end-stage renal disease? So if the creatinine is more than 0.8 at the age of 1 year, then there is always chance. So as a diagnosis, renal dysplasia, recurrent UTI, bladder dysfunction, all these will lead to end-stage renal disease. So we need to look to that also. Valve bladder syndrome, very notorious, even if we do a proper ablation of the valve, because by the time we have done the procedure, already the bladder may have developed the collagen deposits, and then the thick bladder wall and the non-compliant bladder. So it will put the upper tract into risk. In utero intervention, is it a reality or overhype? I'll say overhype till now. So in coming years, whether if there is something new comes, it may be possible. Otherwise, it is too risky to recommend at this moment. So in our experience, 34 children with posterior urethral valve has been successfully treated, and all of them are voiding. None has developed stricture or incontinence. So this is the latest literature on December 4th of this year, showing the feasibility and effectiveness of thulium laser in ablation of posterior urethral valve. So I'll show a video. So this is the endoscopic view. We'll assess the posterior urethra, the bladder neck, and at the same time the valve leaflets. And this is the hypertrophied bladder neck that we'll resect first. Now we'll come to 7 o'clock position. You can see, so beautifully seen, and because the laser fiber is little stiffer, so we can even feel that valve leaflet projecting towards the urethra, to urethral lumen. So after completing on one side, we'll do on the other side also, and if required, if we feel necessary, we'll cut in the 12 o'clock position where the valve leaflets meet there. And immediately after completing the surgery, we will see how the baby voids. As it is a totally bloodless fill and there is no jerk while using Bagby electrode, we can comfortably do the procedure, and after that we can see the completeness by just putting some suprapubic pressure, and the baby will void immediately. If the voiding is not satisfactory, we can again put the scope and see, and any residual valve leaflet will ablate them. So it is the completed procedure. The bladder neck also incised, both the valve leaflet on 5 and 7 o'clock we have incised, and then you will see how the baby voids immediately in the on table. So management of viewer supravesical diversion vesicostomy is required if the valve ablation is not working, or even after putting the feeding tube, the creatinine is not coming down, or the general condition is not improving. These are the techniques we can do. So concluding, early fulguration of the valve after stabilization is the first step in the management. Application of the thulium fiber laser has added a new dimension for treating posterior urethral valve. The laser energy is released by thulium fiber laser, has a short tissue penetration distance, and is strongly absorbed in the aqueous environment, and therefore limits thermal tissue damage and favors early tissue re-epithelialization, reducing the risk of urethral stricture and decreasing the postoperative edema. Identify the bladder dysfunction and manage it accordingly. Judicious time voiding anticholinergic bladder drainage by clean intermittent catheterization is required if the bladder is non-compliant. Post-fulguration, a close watch on upper urinary tract is important. Evidence of non-compliant bladder, candidate for augmentation cystoplasty in the correct time. Deterioration of upper tract function, we may go for renal replacement therapy later on. So EIU guideline, as I have already said, that there is weak recommendation for vesicoamniotic. Rest we have already spoken, they have strong association. This is anterior urethral valve referred to me by Prakriti, my respected senior. So we did this anterior urethral valve. As you can see, the valve is located much distally, so we had some doubt in mind, and while seeing, the valve was in the anterior urethra. So that baby also voided very well. This is the 8-day-old baby who we took for the surgery. Just 1 minute video. At that time, if you have any query or questions, I'll love to take.
Look, very nicely covered. Thank you.
So this is the urethroscope, sir. This is a long scope, so we need some hand-eye coordination when we do with urethroscope. So sir has the luxury with pediatric cystoscope, so it will be easier. But with urethroscope, as we do every day we are doing, so it is easy for us. And you can see the valve here. It is so well delineated. So once we fulgurated, immediately baby started voiding. Thank you, sir. Any questions?
Hello. Oh, you have hypnotized the whole house by your excellent delivery. So how can I thank and how can I congratulate you? At Arup, you have been to our heart medical also in Johat.
Yes, sir.
Oh, why did you not meet me?
I met you, sir.
Because I used to get so many cases that I could have referred to you. And you have not never met me.
Sir, we talked about you.
I have heard your name since long. And he visited probably once or twice weekly, no? Our Johat Heart Medical, my chamber. You use a guide wire. What is the name of that guide wire?
Sir, it is Terumo guide wire 0.035 friends. We get straight tip also. Straight tip but malleable, so it's not going to cause any harm anywhere. So it will, and immediately after that it is stiff. So it will negotiate even the high bladder neck. It will go to the bladder invariably, and over that we can put the feeding tube.
But the catheter that we are going to use will be a feeding tube, right?
Feeding tube.
But the feeding tube will not have a opening on the tip.
No, we will cut, sir. We can cut obliquely and put some jelly, so it is not going to cause any harm because already the guide wire is there. We are just railroading over it.
Yeah, yes, like Saliga technique. Thank you.
Thank you, sir. Sir.
How do you put laser?
Sir, because laser fiber is stiff. So,
where to put it? How distance? How do you put it?
sir, the cladding. laser fiber is transparent, the cladding is blue. So we put the cladding and then gradually withdraw the laser fiber till the tip touches the valve leaflet, and then we fire it.
One more question. Last case you say anti-urethral blood. Why not in the diverticulum?
So initially it looked like diverticulum,
Yes.
but when we did the scopy, because maybe the urethric the jet of water, it looked just like that only. But on mixed-urethric cystourethrogram, it looked like some diverticula was there. But immediately after that, he started voiding right well.
Thank you.
Thank you, sir.
Okay, thank you, Dr. Arup. Common surgical problem. The main problem is the post-surgical complication like stricture, urethral stricture, and bleeding and all. But Dr. Arup Nath has done a nice working very good. He has already completed 34 surgery, 34 surgery using this thulium fiber laser, and according to him, the complication he has found not a single patient has any complications. It's a very good news for all of us. Thank you, Dr. Arup Nath, for your research.